All right, so I think met most of you, but by way of, in case not, by way of introduction, I'm John Schorling. I'm a professor at the University of Virginia and have, along with my wife Sophie, we've been coming here for the past year working on the diabetes project. And tomorrow I'm going to talk about the current status of the diabetes project, with the help of Dr. Stacy and Susanna. We now have over 300 patients enrolled and who are getting regular care here for their diabetes. And I will say, in the program, 10% of the patients we see, out of the 300, about 30 are receiving insulin. And so, Dr. Stacy asked me to review, and Ms. Peggy asked me to review insulin types and uses. Since we do have some more patients who are coming here now, who are already receiving insulin. So what I'm going to talk about today is different types of insulin, the differences between the different types of insulin, how they're used, and then how to start someone on insulin and adjust the dose once they're on insulin. We'll do all that in the next 10 minutes.
9.
9 minutes. Okay, in the next 9 minutes. So the different types of insulin. There are more than this, but there are 4 basic types of insulin that are in common use. The first is rapid-acting insulin. The 2 most common types are Lispro or Aspart. And the main use of those insulins is in patients who are on long-acting insulin. They're given at mealtime. And they're very short-acting, as I'll show in a minute, so that they can be given right at the time that somebody eats. They don't have to be given beforehand. Short-acting insulin is regular insulin, which has been around for a long time. And it's given both with meals, usually 30 minutes before somebody eats. So, and then also in fixed combinations, usually with NPH insulin. In people who are on chronic insulin, and then they, rather than giving it before meals, it's mixed together and they just give themselves 1 or 2 doses a day. NPH is the long-standing intermediate duration insulin that we've used for years that can be given once or twice daily, either alone or in combination with regular insulin. And then the newer, longer-acting agents are Glargine or Detamir, and they're usually given once a day. And basal insulin is the term we use for long-acting insulin that provides a continuous amount of insulin over time, and then the rapid-acting or the short-acting are given intermittently to help cover the glucose load when somebody eats. So the 2 types of basal insulin we use primarily are NPH or one of the long-acting insulins. Oh, you're really not going to be able to see this from the back, so I'm not even going to go there. Can you see that at all from the back? So this shows along the bottom is time, and along the side is the strength of the insulin. So you can see the first curve, this one in black, is the rapid-acting insulins, Lispro and Aspart. And you can see they have a very quick onset, it's pretty high, and then it comes down really quickly. So their peak is between 30 and 60 minutes, and it only lasts an hour or 2. So it's good to use that kind of insulin when somebody eats, because they take it right when they eat, when the glucose gets absorbed through the intestine and the glucose level in the blood goes up. That's the same time the insulin peaks, and it helps control the glucose. Regular insulin has a later peak and a longer duration of action, so that it peaks after 1 to 2 hours, and then it lasts for up to, normally we say this shows out to 12 hours. Normally we say that regular insulin lasts for up to about 8 hours. And so it can also be used with meals, but it has to be taken earlier, as I said, 30 minutes before meals. Then NPH is the one in green, which has a peak after about 4 hours and lasts 18 hours. And then the two at the bottom are the long-acting insulins that last for 24 hours. So, my own preference for patients who have hyperglycemia, if they're going to get insulin, if it's available, is to use regular insulin, because it has a longer duration of action. And if somebody's seen in the clinic and their sugar is 400 and they get regular insulin, it'll last long enough that they can pick up the pills in the pharmacy, and if they're taking, especially if they're taking glipizide, the glipizide will start to kick in while there's still some of the regular insulin. If they're given Lispro or aspart, it's more rapid, so their sugar will come down more rapidly, but then they'll again not have any coverage before they can take their medicine. I know here, often just as we're dealing right now, as we're running out of metformin today, there's always the issue of medicines and what's available. So if what's available is Lispro or aspart, it certainly works. My personal preference is regular is available. It takes a little longer to act, but it lasts for longer. And it's more likely to overlap medicines if they're started when somebody goes home. Any questions about that? So starting insulin therapy, right now, as we'll talk about tomorrow, in the diabetes program, we're using up to 4 oral medicines. So we start with metformin first when we have it. We're going to have to come up with a new plan for the next couple of weeks after today because we're out of metformin. We start with metformin, then we add a sulfonylurea, either glipizide or glibenclamide. Then we add, right now we're using empagliflozin and linagliptin. So all up to 4 medicines. And if each of those medicines can lower a hemoglobin A1C by about 1, someone could come in with a hemoglobin A1C of 10 to 12, and the 4 medicines could get down below 8, which is what's ideal. But if someone can't be controlled even with those medicines, then starting insulin is a reasonable alternative, or something good. It's not reasonable because they don't always have insulin, but it's something to consider. And so the usual starting dose with either NPH or the long-acting drugs is to start with 10 units, or about 0.1 to 0.2 units per kilogram per day. So if somebody weighed 150 pounds, 70 kilos, 10 units would be 0.15 milligrams per kilogram, which is the usual starting dose. And then if someone is started on the medication, ideally, if they can check their blood glucose, it's good. If they have to come back to the clinic to do it, then it's good then it's really important that they come in fasting. And so we saw someone yesterday who'd been coming to the clinic. She actually had been coming to the clinic every week for 4 weeks. And so we could see what her average glucose was over those 4 weeks, fasting glucose. And it was still about 160, so we increased her insulin by 4 units. So that's a reasonable thing to do for the patients who can come back in. If hypoglycemia occurs, evaluate for the cause, and consider decreasing the insulin by 4 units or 10 to 20%. Usually when we start basal insulin, even if it's NPH, we start it in the evening. It seems that insulin is more effective when it's given in the evening. That there's actually the hormonal changes in the body cause glucose levels to go up at night, and so if people get their insulin in the evening, even if it's NPH, it tends to be more effective. Then if somebody gets up to over 0.5 units per kilogram, so again, if somebody weighed 150 pounds, they weighed 70 kilograms, if they were on more than 35 units a day, then we would normally split it if it's NPH and give 2/3 in the morning, about 65% in the morning, 1/3, 35% in the evening. And once it's split, it can either be just as NPH or as 70/30. If you're just, the NPH alone can be given in the evening. If you're starting somebody on 70/30 insulin, then it should be started in the morning because of the regular insulin. That you wouldn't want to give somebody regular insulin later in the day because the regular might cause their glucose to be low at night when they're not awake. So NPH or the long-acting insulins can be started at night. If you're starting 70/30, it should be started in the morning. So that's about 10 minutes. A quick overview of insulin. Any questions, comments? All right, thank you.